All right, yeah, so we're going to move into our next session where we're going to do another Into the Pipeline series on reducing inflammation. So before we move into that session, we're going to have another one of our introduction videos from Dr. Maniscavina.
In Duchenne, the absence of dystrophin means the muscle cell membrane is less stable than in a healthy muscle cell. Due to decreased stability, there are tears in the membrane that allow various molecules to escape the muscle cell while others infiltrate it. This includes markers of cell damage that triggers an alert to the immune system, which then responds with inflammation. In this inflammatory environment, there are a number of factors present that can inhibit how well the cell works. Because the muscle cell membranes can't be repaired, the cycle repeats itself and leads to chronic inflammation. One way to combat this inflammation is the use of steroids, which is the current standard of care. Steroids have a broad range of effects, including suppressing the immune response that generates the chronic inflammation. We know the use of steroids can delay disease progression, and other anti-inflammatory drugs may also provide similar or additional benefit.
All right, welcome back. Joining us on our panel today, we have Rich Abel from PTC Therapeutics, we have Eric Hoffman from Riveragen Biopharma, and we have Chris Spurney from Children's National. So we will have an open Q&A after this, so if you have questions, please submit them to the comment box below. We will get to as many of those as we can when we get to the Q&A. So we're going to start today with Rich talking to us about deflazacort. So Rich, you can go ahead and take it away.
Hey, good afternoon, good morning, good evening, depending on where you are. It's a pleasure to be here with you all today. So again, my name is Rich Abel. I'm the U.S. Medical Head of Neurology at PTC Therapeutics. And the title of our presentation is Deflazacort Evidence for its Role in Slowing Disease Progression. Next slide, please. These are our forward-looking statements as we are a public company. Next slide. So today I'm just going to spend a few times, and you can build this slide, it's fine. Having everyone to understand again, for some of you who may be new to the DMD space, new diagnosis, that over the last 2 decades, there's been a significant amount of long-term published data accumulated to support the benefits of deflazacort in slowing disease progression over prednisone. Supporting this benefit is consistent, well-established body of significant evidence consisting of over several published studies with a large number of patients being monitored, and in some cases, greater than 10 years of follow-up. Can you build the slide, please? I'm not going to go through all of the studies shown here to support deflazacort's evidence, but I'll speak to the ones in orange. You can build again, sorry for that. And you can also see the 15-minute presentation, which will go in depth for some of this, a little bit more for some of these studies. Okay. Please note, everyone, that Emflaza or deflazacort is the only corticosteroid approved by the FDA for the treatment of DMD in the US. And its approval supports the use of Emflaza for males aged 2 years and older. Next slide, please. So in the following slides, again, you'll see consistent evidence of clinical data that support the greater benefit of deflazacort versus prednisone, not placebo, but also placebo, but more specifically against prednisone. This evidence is supported by long-term randomized clinical trials, real-world evidence studies, post-hoc analyses of placebo arms from a number of different studies as shown yesterday with Dr. Craig McDonald and the late breaker, but also natural history studies. I first like to remind you, which is shown here in Emflaza's phase 3 pivotal study, so study 1 in our label, the safety and efficacy of deflazacort and prednisone versus placebo was assessed in 196 boys aged 5 to 15 years of age, and this was done over a 52-week period. The primary efficacy endpoint was the average change in muscle strength from baseline to week 12 compared to placebo. All of the treatment groups, as you can see, demonstrated significant improvement in muscle strength compared to placebo at week 12. After that 12-week period, the placebo patients or participants were reassigned to one of the other three arms, the active comparator arms. The secondary analysis change in muscle strength, so from week 12 to 52 weeks, demonstrated continued improvement in muscle strength of the deflazacort-treated participants versus those who were on prednisone, as shown in red. There was a significant improvement in average muscle strength score from week 12 to 52 in the deflazacort 0.9 mg per kg per day, which is in the label, compared to prednisone. Again, and you'll see here in red. Next slide, please. Just a few studies. So I'll start with the largest DMD natural history study, which is Synergy. And Synergy provides up to 10 years observational real-world evidence supporting the use of deflazacort and DMD. And an earlier assessment of Synergy published by Bello, which is shown here, patients who initiated deflazacort daily deflazacort treatment significantly later. So they were older than the patients who received daily prednisone. They still demonstrated significantly greater preservation of ambulation than the patients taking prednisone. And this was a 2.7-year delay in median age of loss of ambulation compared to daily prednisone. Next slide, please. Now we'll take a look at a real-world retrospective study. So at a single site, Cincinnati Children's Hospital, there was a average follow-up of 11.2 years. And in this study, males receiving daily deflazacort experienced a median age of 2.1-year delay in the age of transition to wheelchair compared again to prednisone. So this is consistent with the demonstrated efficacy from Synergy, and which you'll see if you look at the data, many other studies. I like to say also here, it's not shown, but deflazacort was also associated with a lower risk of scoliosis compared to prednisone. And later onset of scoliosis, as you all may know, is linked to a longer term benefit of preserved muscle function. And this can only be assessed over longer periods of time. If you look at the study again, it also showed benefit over prednisone in a number of time function tests. Next slide. Finally, we'll look at a real-world nationwide review of medical records to evaluate physician satisfaction with switching boys from prednisone to approved Inflaza. In this study, 55 treating physicians responded to a study survey, with the majority giving a desire to slow disease progression and reducing tolerability issues as the main reason for switching their DMD boys from prednisone to Inflaza. In total, 62 boys with the mean age of 6.2 years were switched, and during an average of 6 months follow-up after switching, the clinical global impression outcomes were consistent, demonstrating that treatment with Inflaza addressed physicians' primary reason for switching. This poster is available here at PPMD, and we're happy to announce that it was recently accepted for publication, so that should be out soon. Next slide, please. So in summary, Inflaza, again, is the only FDA-approved corticosteroid for DMD in the US. It forms part of the standard of care and will likely continue to be a mainstay for therapy in DMD. And I think important for everyone to remember is that a substantial and consistent body of evidence to demonstrate treatment benefits of deflazacort or Inflaza as compared to prednisone has been demonstrated. Next slide, please. I'd like to close, but just saying it takes a village. I believe that with all my heart. And I'd like to thank the boys and their families for their participation in the studies, all of the studies, individuals who are instrumental in the conduct of the study and collection of the data, and also specifically at this time, the entire PPMD community. Thank you very much.
Thank you, Rich. Really appreciate that. I have one follow-up question before we move on to Eric Hoffman. So you're probably well aware of the 4DMD study funded by the NIH, which has completed, and we're all anxiously expecting data or hoping for data. This is a tax funder paid study. Have you all been able to compare Emflaza against the 4DMD data to date?
At this point, it's not published. We are aware that it's available, and we're looking forward to seeing the published information.
Okay. Thank you very much, Rich. Okay, our next speaker is Eric Hoffman from Riveragen. Eric, please take it away.
Hi, good afternoon. Great to be here at PPMD. I've been in your meetings since the early days, and so it's great to how far you guys have come and see all the parents again. So I'll be talking about can anti-inflammatory benefits of corticosteroids be separated from their adverse events. And we've just completed a 24-week double-blind trial that I'll give results from here. Next slide, please. So just a disclaimer for Santhera. We're in partnership with Santhera, and they're publicly traded. Next slide. So the goal is to, what we've done is tweak the structure of corticosteroids, and really just in one area, which is that circle there. And we've changed how it interacts and functions relative to other corticosteroids like deflazacort or prednisone. The goal of this program is to keep the great effects that Rich just spoke about, but then also try to reduce the safety concerns. And so that's where the activity of vamorolone, because of this different chemical structure, interacts with the receptor differently, and then reduce, and then a lot of that we understand as far as how it interacts with the genome. It changes mineralocorticoid activity compared to the other corticosteroids. And it's not a substrate for regulation like the other corticosteroids. And so the hope is that we see then less side effects or safety concerns. Next slide. So the trial I'll talk about today, in previous PPMD meetings, I've talked about a long 2.5-year trial that was 48 DMD boys. So this was a double, but that was open label. So this one's double blind and has both placebo and prednisone as arms. And it's 2 different doses of vamorolone, both 2 and 6 mg per kg. And so patients were randomized, 121 steroid-naive patients, 4 to less than 7 years old. And this was at 33 sites in 11 countries. Was randomized into these 4 different dose groups. And I'll just be talking about this first 6-month study. All the patients did transition to vamorolone, and there's still some patients finishing up that part. And then patients go into expanded access or compassionate use after the trial. So we're just going to focus on this 24-week data. Next slide. So our primary outcome, as you know, clinical trials have primary and secondary outcomes. So you generally just pick one thing as your primary outcome, like one deck of cards, you have to win that hand. And so ours was time to stand velocity or speed against placebo at that 24 weeks with the higher dose, the 6 mg per kg. And so here you see the placebo gets slower over time. So whereas kids on vamorolone, the high dose get faster. If we look then and change that to seconds, and so you're inverting, this is velocity or speed, this is how many seconds. You can see that the placebo guys take a little longer to stand up over 6 months, whereas vamorolone takes less time. And it's very similar to prednisone. Next slide. All the outcome measures looked similar to time to stand. So here we're showing 6-minute walk and North Star, but as well time to climb stairs and 10-meter run walk all looked very similar to time to stand, and all were highly significant relative to placebo. And you see that both doses showed similar effects. So you see the 6-minute walk, longer distance compared to placebo, and North Star ambulatory assessment, about a mean of a 3-point improvement out of that scale over that 24 weeks or 6 months. And again, both doses highly significant. We then turn to the goal of the program is just if we can see lower side effects as well, safety concerns. So just looking at adverse event reporting, it seemed that there were, if we look particularly at corticosteroid-associated side effects, less in the vamorolone-treated groups compared to the prednisone group. Next slide. One thing we had seen in the 2.5-year-long study that vamorolone-treated kids grew normally. And that's what we saw in this 24-week as well. So you see prednisone and all the corticosteroids stunt growth. So it keeps kids from growing normally. It changes bone remodeling. Whereas vamorolone, the higher dose, actually increased growth a bit. And this is what we saw in the long-term study too. This is probably catch-up growth because Duchenne kids are in the lower quartile of height, even at baseline before starting any drugs. And there seems like perhaps this higher dose helps catch up. And the bone biomarkers were consistent with that. It's well known that corticosteroids shut down bone remodeling, and that's probably part of the growth. And you saw that in this trial too. These are commonly used bone biomarkers to see how bone is remodeling, used in over 400 clinical trials and over 4,000 papers. And again, prednisone shuts those down over that 24 weeks, but vamorolone actually increases a bit compared to placebo. So again, this change seemed to have lost the bone morbidities, at least as evidenced by biomarkers and height. Next slide. So just in summary, vamorolone shows significant clinical improvement in motor outcomes over a broad dose range, 2 and 6, across all the outcome measures. Fewer clinically relevant adverse events typically associated with steroids, and vamorolone shows less bone morbidities associated with corticosteroids. So normal growth velocities and the bone biomarkers were clearly changed. Additional data is under analysis. Next slide. I think that's it, right?
Great, thank you so much, Eric. Just one brief follow-up, and even from the polling you saw before, that so many are on deflazacort. Can you just tell us why your drug wasn't studied against deflazacort in the study?
Yeah, the program was done. All these trials take a while, and it was designed quite some years ago and discussed with regulators some years ago. So before deflazacort was approved. And because prednisone was more commonly used in Europe at the time, and because Europe, you get into regulatory discussions, and actually EMA and FDA disagreed with how we should even include comparators. So you have to negotiate with regulators. So at the time, it was just decided to move forward with prednisone.
Great. Thank you so much, Eric. We'll see you in the panel discussion. Our next speaker is Chris Burney with Children's National Medical Center. Chris?
Great. Thanks so much for having me. Welcome, everyone. I'm coming from a little bit of a different perspective here. The presentations that Rich and Eric gave showed you some extensive kind of clinical trial data. And I'm going to now kind of pull everybody back to the very start of one of these journeys, looking into medications for Duchenne. So the title of the trial that I'm working on is a single escalating dose pilot trial of Canakinumab, which is known in the market as Alaris. And we're going to assess safety and biomarker changes in children with Duchenne. So next slide. I have no disclosures, and support for this clinical trial is provided by the Foundation to Eradicate Duchenne. Next slide. Obviously, our whole topic here is decreasing inflammation, and we've already spoken a bit about glucocorticosteroids as the gold standard. They're anti-inflammatory, but they do have significant side effects. And so really that's what we're looking to address here with our program. Certainly there's been a lot of focus with exon skipping therapies. You get a restoration of the partial dystrophin protein in some of these specific mutations. You get an improvement in your membrane stabilization, and you get decreased inflammation, but you don't get a loss of, or all the inflammation doesn't disappear. And so you do have chronic inflammation that remains and will, disease will progress over time. I am a cardiologist, and so certainly one of our concerns is cardiac muscle. It also lacks dystrophin and is susceptible to the progressive disease that we call cardiomyopathy. And standard heart failure medications that we use do not directly target cardiac muscle inflammation. And so that's another kind of perspective that we're looking at for this new medication. Next slide. So when you talk about inflammation in the body, you talk about NF-kappa B mediated pathways, and you can see there are lots of these pathways on the slides. And there have been a lot of animal models and human studies that have shown that blocking NF-kappa B reduces inflammation. And you can see the two red boxes show the inflammatory pathways regulated by NF-kappa B. But if you look at some of the other pathways, there are also some beneficial pathways that NF-kappa B mediates, and that's a pretty common thing within biological processes, that some pathways are positive and some pathways are negative. So if you by knocking out NF-kappa B, you might be knocking out some of these positive pathways. So if we're focusing on the inflammatory pathways, the two red boxes, you can see the lower one says cytokines, and those are chemicals within cells that cause inflammation. And one of those chemicals, the very first one listed there, is IL-1. It stands for interleukin-1. So this is one of the cytokines in the body that causes inflammation. And studies that have looked at NF-kappa B blockade have shown decreasing levels of IL-1 when we see this beneficial effect of decreased inflammation. So that's where we're going to target our clinical trial. You can go to the next slide. So there is a FDA-approved drug called Canakinumab, and this blocks interleukin-1 beta signaling. This drug is a monoclonal antibody, so it is a protein that is produced by the immune system, and it is directed at binding interleukin-1 beta, right? Our immune system goes out and it binds normally foreign objects and bacteria. But here we've created an antibody that's going to bind that cytokine interleukin-1 beta. And so you see on the left-hand side, when interleukin-1 binds its receptor, you get these inflammatory pathways. And then when Ilaris is administered, it binds up the free interleukin-1 beta, and then it doesn't bind to the receptor, and the signaling is blocked. So it's a bit more of a really addressing one specific pathway within this whole inflammatory process. Next slide. So when we look at the overall rationale for the study, we know that inflammation plays a major role. Steroids have certainly demonstrated that decreasing inflammation is beneficial, but they have significant side effects. When we've looked at studies where NF-kappa B activity has been blocked, it has shown to reduce levels of interleukin-1 beta. And we see with that decreased inflammation in DMD, and that's similar to what you see with steroids. So we are now looking to directly provide interleukin-1 blockade with canakinumab therapy, and this will hopefully reduce both skeletal and cardiac muscle inflammation and reduce or without the side effects that are related to steroid use. And one benefit is that canakinumab has been FDA approved in pediatric and adult subjects for some chronic inflammatory syndromes that I discuss more extensively in the full presentation. Next slide. So again, we're at the very beginning of this. Our primary objective is safety. We want to show that giving canakinumab to children with DMD is safe. And as I said, it's been approved in children with chronic inflammatory diseases. So in all likelihood, I think we will demonstrate that it is safe in children. We are selecting steroid-naive boys at a young age because we can't have the steroids in their body because we won't be able to tell the effectiveness or the safety of canakinumab if steroids are also present. And then secondarily, we will draw some serum biomarkers to show if we see some decrease in inflammatory biomarkers related to canakinumab therapy. Next slide. Our design, again, we're at the very beginning here. So it's an open label. Everyone knows that they're getting the drug. It's a single dose. We're just testing one dose in the children. And then we will have 3 subjects, which get the lower end of the FDA approved dose, which is 2 milligrams per kilogram. We will then present those 3 subjects to our data safety monitoring board. If our safety profile looks good, we'll then do 3 subjects at the higher FDA approved dose of 4 milligrams per kilogram. We'll be monitoring for clinical side effects after the injection, and then 14 days after, 30 days after. And then obviously we'll always be in contact with the participants to discuss any concerns. We will be drawing laboratory values to make sure there are no abnormalities in the blood chemistry levels, and then we will save some of that blood for biomarker analysis. Next slide. Our expected outcomes, we want to show that Canakinumab is safe and well tolerated in DMD. We hope then to show that Canakinumab reduces biomarkers of inflammation during this 1-month dosing. And that's the approved dosing for Canakinumab in these other chronic inflammatory syndromes. It's a once-a-month dosing. So we hope then this gives us data to support a larger clinical trial. And we can use this monthly dosing of Canakinumab. And really our goal is to either reduce the amount of steroids that children need when they're using Canakinumab, perhaps use Canakinumab early and start steroid dosing later, perhaps continue the Canakinumab, use lower steroid. However, we can create a more beneficial clinical effect with a reduction in side effects. Next slide. If you would like more information, feel free to email me there on the slide at clinicaltrials.gov. There is our trial number. Those are also included in the full presentation. Next slide. And as with Eric and Rich, thanks to all of you for your participation in research and your support of research. And again, a thanks to the Foundation to Eradicate Duchenne for funding this study. And then thanks to Parent Project Muscular Dystrophy for having me here today. Thanks very much.
Thank you so much, Chris. Just one follow-up before we get to the panel. I think you touched on this, but I want to clarify something. If we find this drug to reduce inflammation, do you see it being used on its own or perhaps even in combination with a low-dose steroid?
Yeah, absolutely. That I think is our goal, and especially because it's been approved very, in young children at 2 years of age, could provide kind of a buffer therapy in the younger children, or at least starting steroids at a lower dose, or giving some inflammatory therapy until they start steroids at, the 5 or 6 years of age.
Thank you. Thank you so much for clarifying. All right, Eric, you want to take the panel away?
Yeah, and again, if you have any questions, please submit them to the comment box below. So the first one we had was kind of asking about the weekend dosing and potential reducing side effects. So Rich, I'm going to throw this one to you, but we obviously have a lot of families. We have a number of families on prednisone. Some of them do weekend dosing. I wasn't sure if you were able to see the polling. We even saw about 10% of respondents say that they were on a weekend dose of deflazacort. And so the question was if there's any efforts underway to look at alternate dosing with deflazacort from PTC.
Thank you very much for the question. And yes, we appreciate that patients and their families, along with their physicians, have been making a decision to try to manage their side effects on prednisone and also on deflazacort over a number of years. Would like to say that it is not a plan at this point to look at alt dosing and deflazacort. However, we do have a number of studies that we, as I just mentioned, and what we see from those studies, including real-world studies, is that a large number of the deflazacort patients, usually between 85 and greater percent, are on daily deflazacort, right? Versus prednisone patients who tend to be around 60-65% daily deflazacort, and for reasons which we all believe is to manage some of the side effects that prednisone that they are dealing with prednisone and not necessarily seeing with deflazacort. They're forced to have to look at these alt-dose regimens. So we don't really see it as a need based on the data that's been provided to been shown in the studies to look further at the need for patients to look at alt dosing of deflazacort. But we'll continue to evaluate the data as it comes in.
Thank you. Eric, can you talk to us a little bit about that transition from those patients that were on prednisone to vamorolone in the trial? Obviously, we have a lot of patients that are on steroids, given it's our standard of care. So, if vamorolone's approved, that's going to be something patients and clinicians have to think about, that kind of transition.
Yeah, in the clinical trial, we have a 4-week tapering. It's seen most of the physicians tapering off corticosteroids before going on to vamorolone. A lot of the tapering has to do with adrenal suppression and concerns with that. But there isn't a lot of data on that. There's not much scientific evidence that one type of tapering is better in any disease. So it's more just sort of pragmatics and what people are comfortable with. So there's no real clear evidence that there would be any danger by any type of tapering. So there's even discussion in an upcoming trial whether we just go from one day corticosteroids to the next day vamorolone.
Okay, thank you. Chris, this question came in for you about Canakinumab. Obviously, a lot of our Becker patients aren't necessarily on chronic steroids, but is something like Canakinumab, if it has a lower side effect profile, is that something that could be considered for those patients where there's maybe some benefit here for a drug like this?
Yeah, I think absolutely. Again, sometimes Becker suffers from less preclinical research in it, and so there's not a lot of the IL-1 beta is a very common inflammatory muscle pathway, so it would be expected that it would be in Becker muscular dystrophy also, and that they certainly could benefit from that. Probably not much data to absolutely support that at this point, but as a model, I think it fits very well.
Oh, thank you. Yeah, we've had quite a bit of conversation about Becker patients, I think, this conference, which has been really exciting to see in that underserved population. Rich, this one's for you about deflazacort. So you've shown a lot of data in this presentation, as well as what we saw from Craig's presentation the other night about deflazacort compared to prednisone in terms of ambulatory function. Do you all have data on respiratory outcomes and kind of what that looks like in terms of if there's any differences between deflazacort and prednisone?
Yeah, so here at PTC, that's one of the things that we're continue to focus on to try to be a pioneer at looking at some of these later onset disease milestones, including pulmonary function. In a recent publication from Martin et al., that Cincinnati cohort study that I showed, one of the outcomes that we showed was percent predicted FVC percentage, right? And so what you can see is patients on deflazacort versus prednisone showed a 9% benefit over prednisone in terms of FVC. So it's there. We're currently looking at ways of evaluating other, let's say, later endpoint assessments, including power within non-ambulatory patients, hand-to-mouth, pool, et cetera. So we're looking into that now.
Great, thanks.
So there's a benefit.
And then Eric, for that extended access portion of the trial, can you just share what dose are the patients on for that portion?
Since we've shown efficacy and safety over this broad dose range, 2 to 6 mg per kg, threefold, we just let the physicians decide with the families which dose they'd like. Most of the families, we had an investigator call with a number of investigators worldwide that have these patients in expanded access. Many of them are choosing the higher dose, often at the request of families, but we leave it up to them.
Okay, thank you.
I wanted to ask a question to Chris. Chris, given your drug and its history, how are you going to monitor cardiac function changes in patients?
Well, certainly the cardiac function is a longer term issue, right? And it's even a similar problem now when we start to use other medications like lisinopril earlier on in these kids, because we think, the benefit we're going to see is going to be a bit down the road. So certainly, we use our standard technology of echocardiogram, but that really shows us function and really just the function of the muscle as a whole. So most of the early cardiac surveillance is now moving towards cardiac MRI. And it's a way to more directly look at fibrosis, which is a marker of inflammation within the muscle. And so that's certainly a technique that we would look at for if we started a larger clinical trial using cardiac MRI to try and tease out whether we can identify decrease in inflammation and fibrosis during the treatment period.
Thank you.
All right. I'm going to keep going around the horn. Rich, we a little bit yesterday, and again in one of the graphs you showed today during your presentation, the question is about kind of when we start to see some of those differences between prednisone and deflazacort. And I think in the graph you showed, by 52 weeks, you started to see some of that separation from kind of the evidence that PTC has collected through trials. Is that kind of the time point we're expecting to start to see some of those differences in ambulatory function after initiation, or a little bit further down the line? Obviously, as you showed, does push some of the milestones, but kind of when we start to see those effects.
Yeah, so this is a heterogeneous population, obviously. What I showed in the previous slide for our pivotal study, phase 3 study, which is published by Griggs, study 1, it shows very early benefit of deflazacort versus placebo as early as 6 weeks. Right, so that's a very early time point to see a difference. And that same study, yes, it goes out through 52 weeks to show a difference between prednisone. But I think overall it depends on the patient population, the assessment that you're looking at, and a number of other factors to see a difference. But as early as six weeks versus placebo.
Okay, thank you.
Sure. This next question is for Eric. Given you have the 2 milligram, you have the 6. What do you think, if Phenerone is approved, will be on the label for the dose?
Well, since in this double-blind trial we show demonstrate efficacy and safety of both doses, we'll ask for both doses to be on the label.
Great.
So this one coming in, Chris. So if the data looks promising from this kind of initial trial, if the safety looks good, are there plans to move to a second larger study? And would that be in that same 2 to 5 population, or would you think about maybe moving to some slightly older patients, though given what you said, likely still steroid naive?
Yeah, that's absolutely the plan. And I think you kind of bring up the major point here is looking for that population that is steroid naive, and the fact and the benefit that we have a drug that has been approved in 2 years and older. And so that younger cohort is probably going to be the initial area of focus. It certainly gets to be in that area where a lot of competition for subjects to participate in trials. So it's a little bit of trying to find what will work best for enrollment and most beneficial to the subjects. But my suspicion is that earlier cohort will be the initial focus.
Okay, great, thank you. No, and that is certainly a very competitive age that we see a lot of trials going after. And actually I have a quick follow-up one that came in, just kind of about what the side effect profile might look like, given
Sure.
the evidence that we know from other diseases.
Sure, it does have an immune modulation effect, just like steroids and other anti-inflammatories. And the main side effect profile has been in kind of upper respiratory tract-like infections. And so you do see a higher increase of cough, runny noses, sore throats, a bronchitis a little lower, and then there are some mild GI symptoms where you can get some diarrhea or gastritis. Most of these things, although the label will say you're at risk for a serious infection, all of these things have responded to normal, antibiotic therapy if it's a sinusitis or something like that. So you do see a increase in some of these upper respiratory symptoms, but they are treatable with standard therapies, and they don't seem to be, really more severe. And there is even I put some information about COVID infections and just its relation to the COVID. It's actually been studied as a beneficial therapy in COVID because of the inflammation.
Great. Thank you. And I'd like to thank all of our panelists for joining us today for this discussion. We really appreciate it. And I think we're going to move on to our next Pat Chat.
Yes, we certainly had a lot of questions there, and I could have kept going, quite frankly, and apologize to those who we didn't get to your question. We will follow up. So our next session is going to be with Dr. Geo Raphael Fortney, who Pat's going to speak with in the next installment of our In Focus series. Pat, I'm going to hand this over to you officially, and welcome Jill.
Jill, welcome. So happy you could join the conference this year. How are you?
Good. Thank you for having me.
Good. We're thrilled to. So, Jill, you've been working for a long time on the NF-kappa B called Phenerone. Can you give us a little background on Phenerone and, how that came to be something of interest? And we just actually heard from a panel of Eric and Chris Burney and Rich from PTC talking about anti-inflammatories, and Chris Burney talking about the NF-kappa B specifically. So could you talk to us a little bit about Phenerone?
Sure. So Phenerone is a mineralocorticoid receptor antagonist, and so is spironolactone. So those are two of the drugs that have been FDA approved for a very long time and used in pediatric populations and congenital cardiomyopathies and in adult heart failure populations. So, they have decades of safety and efficacy data across a wide variety of patient populations with very few side effects. There's a third generation drug that Bayer has been developing, which we've also tested, called Phenerone, which is a non-steroidal mineralocorticoid receptor antagonist that can be used at even lower dosages. That's undergoing FDA review right now for CKD. And so what we found with mineralocorticoid receptor antagonists is that not only, so they've been used, for decades for heart failure. We had originally worked really closely with a cardiologist named Dr. Subbaraman, who was sort of a bioengineer by training and did cardiac MRI in patients. And we went back and forth for about a decade, understanding that our animal model of cardiomyopathy for DMD was similar to what was showing the same sort of steps of pathology as to what was happening in patients, and realized by going back and forth between the mouse models and patient cardiac MRIs that we could detect abnormalities in the cardiomyopathy years before heart failure. So 5 to 7 years before you could detect strain rate abnormalities. So coming to understanding that this cardiomyopathy development was a long process, we asked the question whether you could use heart failure drugs much earlier in the progression of the disease and actually slow down or prevent progression of cardiomyopathy and prevent heart failure. And so we did a preclinical study in the mouse models, and to our surprise, not only did it prevent cardiac damage and improve cardiac function, but it had all of these positive benefits on basically each part of the pathology of skeletal muscle. So it improves muscle force, it protects muscle membranes from damage, it helps inhibit the fibrosis and the fibroblasts that are making fibrotic factors. And most recently, we found that it is actually also an anti-inflammatory. And the cytokines that Dr. Spurney was talking about, which are inhibited by prednisone, are also inhibited by mineralocorticoid receptor antagonist treatment by Phenerone or spironolactone. And so we're now trying to understand what the anti-inflammatory exact properties are in the heart, in respiratory muscles, and in limb muscles, because the inflammation in all of these muscle types is actually quite different from each other, because the heart and the diaphragm are protected by your rib cage and they're not used to normally responding to damage, but limb muscles get damaged in normal people all the time. So they have a much more robust inflammatory response to respond to normal damage. So we're really investigating whether the anti-inflammatory properties are the same in each type of muscle to be able to, again, use a Phenerone in a combinatorial or a temporal treatment for maximum efficacy.
So thank you for that, Jill. I know that, first of all, we're always concerned about the heart and asking, how can we prevent or delay the cardiomyopathy that occurs in Duchenne? And I am aware that, some of the pediatric cardiologists who are generally pretty conservative, right, are beginning like an ACE inhibitor or an ARB very early on. And I'm seeing more and more that they're combining a Phenerone or spironolactone with that. But it's, I'm generalizing now. Sometimes I see them starting about the age of 7 plus or minus, right? Depending on the patient and the discussion, I'm certain. But if you had your druthers today, would you start a Phenerone early? And how early would you start it if you were thinking? Or are you doing some studies to sort of flesh that out?
So we're actually currently recruiting for a trial with spironolactone versus prednisone in 4 to 7-year-old boys, because again, we think that spironolactone and a Phenerone have this benefit on skeletal muscle. So we've already published 2 trials with Subaraman, who is the cardiologist who ran the trials, on showing that spironolactone and a Phenerone show equivalent efficacy on preventing the cardiomyopathy, which has a later onset. But we actually think that the earlier that you treat, you'll have a greater benefit on the skeletal muscle pathology and be able to increase muscle force and prevent more membrane damage and muscle damage and prevent inflammation, which will continue to exacerbate the disease. And I apologize for the noise in the background. The power just went out from a storm, and that's the backup.
Oh my gosh. Well, good. I'm not in Ohio these days for that storm, so happy to be in DC. Okay, so if you're this trial that you're recruiting for, are you looking at 2 arms? One is prednisone, one is spironolactone, or have you? We just had this discussion about using an NF-kappa B to decrease the steroid regimen or decrease the steroid dose. Would you think of a third arm with I don't know, daily spironolactone and weekend dosing of steroids? Would that be reasonable to think about?
Yeah, it's probably not, because glucocorticoid receptors, which which prednisone and deflazacort target, are actually very, very similar. It's the closest possible protein family member to mineralocorticoid receptors. And so deflazacort, the metabolites that are actually active and bind to the receptor for glucocorticoid receptor for prednisone and deflazacort both actually bind mineralocorticoid receptors. So they actually compete for the efficacy of Phenerone and spironolactone.
So is it a wrong assumption to say that it could be that your steroid is masking or diminishing the effect of spironolactone, or
Yes, we've definitely shown that in mouse models and preclinical studies that using prednisone in combination with allopurinol or spironolactone dampens its effect on both skeletal muscle and the heart. And in the clinical trials, we actually tried to recruit patients who were no longer taking prednisone or deflazacort, but only had a handful of patients that were willing to stop, even though they were mainly non-ambulatory patients to meet the cardiomyopathy inclusion criteria. But sort of anecdotally, some of the higher responding patients who had the best outcomes were the patients who were not anymore taking prednisone.
And if people are interested in participating, they can contact you. Who?
Kevin Flanagan is the PI. Kevin Flanagan and Megan Waldrop at Nationwide Children's Hospital are the like neurologist colleagues who do the patient care. I just come up with new ideas in the lab.
Well, Jill, thank you. We need to have more discussion about this because I do think these NF-kappa Bs are really going to be useful in Duchenne. And Dr. Woodcock has said repeatedly, you're not managing the inflammation that occurs in this disease very well. So I'd love to talk more about this, and we'll come back to you just to do just that. Thanks, Jill.
Thank you so much, Pat.